Imagine waking up in a hospital room. The very first thing you hear is the rhythmic beep of a cardiac monitor.
Right, classic hospital soundtrack.
Exactly. And then the first thing you feel is this tight piece of tape on the back of your hand. Or, maybe it's on your neck or your collarbone, just anchoring down this clear plastic tube that disappears right under your skin.
Yeah, and if you or a loved one are ever admitted to a hospital, there is actually a 60 to 90% chance you're going to get one of these.
That high.
Oh, absolutely. We're talking about vascular access devices here. So your standard IVs, midlines, central venous catheters, all of that.
Right, which makes sense. I mean, it's often the very first medical intervention a patient experiences when they're admitted.
It is. It's so incredibly routine that honestly, both patients and healthcare workers tend to just view it as background noise. It's just, standard hospital furniture at this point.
But that life-saving plastic tube comes with this massive, totally invisible
A
catch.
very dangerous catch, yeah.
Because the moment that needle punctures your skin, you have essentially built a direct, multi-lane highway for bacteria. It completely bypasses every single one of your body's natural immune defenses.
You're giving pathogens a VIP pass straight into the bloodstream, basically.
Literally. And when those bacteria take that exit into the blood, you are looking at a central line-associated bloodstream infection, or as the medical community calls it, a CLAB-SI.
And we really need to stress that a CLAB-SI is a catastrophic event. We are not talking about like a minor fever that delays your discharge by a day.
Right.
These are systemic, completely life-threatening infections. And the clinical data shows that depending on the severity and the organism involved, a single CLAB-SI event costs a hospital anywhere from $6,000 to $90,000 to treat.
$90,000 for one infection.
For one event. It's a staggering financial metric. But, honestly, that pales in comparison to the physical toll on a patient whose immune system is likely already compromised.
Which sets up our mission for today's deep dive. We are pulling from this massive stack of medical research, CDC guidelines, clinical trials, and systematic reviews to answer one highly specific, incredibly high-stakes question.
The million-dollar question.
Right. What entry point sealing techniques or emollient protections actually prevent bacterial contamination at these cannula insertion sites?
It's all about guarding the entry.
Exactly. Think of the skin as a castle wall. When you put a catheter in, you're lowering the drawbridge. Our mission today is figuring out the absolute best way to guard that open bridge so the patient actually survives their hospital stay.
I love that analogy. And to appreciate the really cutting-edge sealing technologies we use today, we kind of have to look at the history of failure in vascular access.
The old methods were pretty flawed, right?
Oh, surprisingly primitive. For the longest time, the standard of care was just nurses securing these insertion sites with standard medical tape and totally opaque gauze.
Wait, opaque, which means you can't even see the puncture wound at all.
Exactly. If the site is getting red or inflamed or, actively leaking pus, it is completely hidden under a bandage.
Until they peel it off days later. That sounds like a terrible idea.
It was a massive blind spot. So the medical field recognized that and transitioned to something called standard polyurethane transparent dressings.
Okay, I think I've seen those. You'll see them referred to as SPUs in the literature, right?
Yeah, SPUs. They're these thin, sticky, clear films that look almost like a piece of cellophane stretched tightly over the IV site.
Which on paper sounds like the perfect solution. I mean, you get a barrier to keep the dirt out, but the nurses get a clear window to monitor the site for infection without ripping off the bandage.
The intention was great, definitely. But the physical properties of the polyurethane created this massive unintended consequence.
Uh-oh.
Yeah. These dressings are only semi-permeable, so they trap the heat radiating from the patient's body, and they trap the natural moisture evaporating from the skin.
Oh, I see. It's like wearing a plastic raincoat in the middle of a really hot summer day.
That is the perfect way to describe it.
Because your sweat has absolutely nowhere to go, so you just become damp and miserable underneath it.
Exactly. And that trapped moisture creates a microclimate right under the dressing. It becomes an incubator.
And bacteria love an incubator.
Right. If you know anything about microbiology, you know bacteria absolutely thrive in warm, humid environments. The SBU creates this tropical resort for the patient's own natural microflora.
Like what kind of microflora?
We are talking about organisms like Staphylococcus epidermidis. It lives harmlessly on the surface of your skin every single day, but it becomes a deadly pathogen the second it gets into your blood.
But wait, I want to challenge the mechanical side of this for a second.
Sure, go ahead.
Let's say we do have a bit of moisture under that clear sticker. If the catheter is taped down securely with medical-grade adhesive, How are the bacteria actually making the jump from the sweaty skin down into the vein? I mean, shouldn't the plastic tube be plugging the hole it just created?
You would think so. It definitely looks like it plugs the hole, but the failure happens on a microscopic level.
Okay, how so?
Well, standard polyurethane dressings are designed to adhere to the skin, right? But they do not form a rigid chemical bond with the plastic of the catheter itself.
Oh, so they're just laying on top of it.
Exactly. So as the patient breathes or shifts in bed, or even as that heavy 5E tubing gets bumped by a passing nurse, the catheter undergoes a microscopic backwards and forwards motion.
Sliding in and out of the skin.
Yes. The medical term in the literature for this is pistoning.
Pistoning. That sounds, yeah, that paints a picture.
It is the fatal flaw of traditional securement because every single time that catheter slides out even a millimeter, it gets exposed to that thriving, humid population of Staphylococcus under the dressing.
Oh, I see where this is going.
Yep. When the catheter slides back in, it drags those bacteria down the extraluminal tract.
Which is the tiny space between the outside of the catheter and the inside of the vein.
Exactly. So the securement device itself is actively plunging the pathogens directly into the bloodstream.
Wow. So the clear polyurethane film isn't just failing to protect the patient, it's literally breeding the bacteria. And then the looseness of the dressing is actively delivering them.
Yes. We basically engineered a front row seat to watch our own defenses fail.
That is wild. So I imagine the realization of that mechanical failure forced a pretty massive pivot in infection control.
A huge pivot. The medical community realized physical barriers alone were just completely inadequate, so the strategy shifted toward chemical warfare at the entry point.
Which brings us to chlorhexidine gluconate, which pretty much everyone in the hospital just calls CHG.
Right, CHG. It is a highly potent, broad-spectrum germicide. The thinking was, if the physical drawbridge is going to inevitably leak, we need to embed a chemical weapon right at the puncture site.
Makes sense.
Yeah, major infusion therapy guidelines, like those published by the INS and the APSC, they strongly mandate the use of CHG-impregnated dressings for most patients.
And you see this deployed in a few different ways in the research. The clinical reviews highlight CI sponges, like the BioPatch, which is this little foam disc that slips around the base of the catheter.
Yep, very common.
And then you have CI gel dressings, like Kigaderm CHG, which actually incorporates the germicide directly into a clear gel pad. So to stick with our castle analogy, we've accepted the drawbridge is open, but we've dug a moat of acid around it that kills anything trying to march across.
That is exactly what it is, and the clinical application for this is very rigorous.
Oh, so?
The standard protocol requires prepping the skin with a solution of 2% CHG mixed into 70% alcohol, and the nurse has to let that air dry completely to maximize the bacterial kill rate.
Right, you can't just slap it on wet.
Exactly. Only after it dries do they apply the CHG-impregnated dressing. And the empirical data here is incredibly robust. Extensive Cochrane systematic reviews and CDC evidence summaries demonstrate that these chemical dressings drastically reduce catheter-related bloodstream infections compared to the old standard films.
Yeah. So the chemical moat absolutely works.
It works very well against the bugs.
But pouring acid in the moat creates a lot of collateral damage to the surrounding landscape, doesn't it?
Unfortunately, yes. You're referring to contact dermatitis.
Right.
CHG is ruthless against bacteria, but it can be profoundly harsh on human tissue. The clinical trials tracking these dressings report elevated rates of severe skin reactions.
Like what kind of reactions are we talking about?
We see everything from severe erythema, which is intense redness and inflammation, to localized blistering and skin eruptions directly under the dressing.
Oh, man. My mind immediately goes to the really vulnerable populations. Like, if this chemical can blister the skin of a healthy 40-year-old adult, what is it doing in the neonatal intensive care unit?
It is devastating for premature infants. Neonatal skin is underdeveloped, it's incredibly fragile, and it's highly permeable.
So it absorbs everything.
Exactly. A CHG concentration that causes just a mild rash on an adult can cause severe chemical burns and literally strip the skin off a premature baby.
That is horrifying.
It is. The guidelines actually explicitly restrict these dressings for patients under 2 months of age because of this. Clinicians are forced into this terrible balancing act.
Weighing the mortal risk of a blood infection against the near certainty of causing severe, painful trauma to the patient's skin.
Exactly. It's a horrible choice to have to make.
Which means we are essentially stuck. The clear stickers let the catheter piston back and forth, dragging bacteria in. The chemical dressings stop the bacteria, but they chemically burn the skin.
That was the exact dilemma.
So we obviously needed a physical seal that actually stops the pistoning, eliminates the moisture, and blocks the bacteria, but without melting the patient.
Right. And that gap in the market led to what has to be the most disruptive technology in vascular access today.
Liquid adhesives.
Yes, liquid adhesives. It is a total paradigm shift. It began gaining serious clinical traction with trials like the Sticky Y trial.
The Sticky Y trial, appropriately named.
Very on the nose, yeah. Researchers tested a gum mastic liquid adhesive called Mastisol, and they discovered that compared to standard medical adhesives, the liquid mastic created a profoundly stronger, longer-lasting bond with the skin.
But it wasn't just about the strength, right?
Exactly. The most important finding came from a microbiological sub-study within that trial. It proved the liquid adhesive actually decreased microbial colonization at the insertion site.
Okay, so we are essentially talking about medical superglue.
Basically, yes.
I have to admit, when I first read about this in the sources, the idea of supergluing medical equipment to a human being felt incredibly counterintuitive.
It sounds a bit sci-fi, I know.
Yeah, but the new gold standard the trials point to are cyanoacrylate tissue adhesives, specifically products like Secure Portive FEF, which is a specialized blend of 2-octyl and N-butyl
And
cyanoacrylate.
the history of cyanoacrylates actually traces back to wartime, where they were used for rapid wound closure on the battlefield.
Wow.
Yeah, but formulating them specifically for vascular access solves the three major failures of traditional dressings simultaneously.
Okay, walk me through the three.
First, it completely neutralizes that mechanical failure we talked about. By applying a single drop of this cyanoacrylate blend right at the insertion site, where the catheter enters the skin, it secures the plastic tube up to 10 times better than a standard dressing.
So it effectively anchors the catheter to the skin structure itself.
Exactly. It completely eliminates the pistoning effect. The catheter simply cannot slide in and out. The drawbridge is locked down tight.
Okay, that's one.
Second, it provides immediate hemostasis. Puncturing a vein inherently causes bleeding or oozing around the catheter.
Right, it's a fresh wound.
Exactly. The liquid adhesive polymerizes instantly on contact with the blood and tissue. It seals the wound and stops the oozing immediately.
Oh, so this keeps the insertion site perfectly dry, which strips away the moisture that bacteria need to multiply.
You got it. And that leads directly to the third benefit, which is, frankly, the most impressive part.
I think I know what this is.
It immobilizes and kills the bacteria entirely without using harsh chemicals like CHG.
The mechanism here is so fascinating because the glue is highly anhydrous, meaning it contains virtually no water.
Right. And because it is anhydrous, it desiccates the microscopic environment. It deprives the pathogens of the water they need for cellular function. One of the in vitro studies evaluated this exact cyanoacrylate blend and found it achieved a 99.97% immobilization and kill rate against highly dangerous pathogens.
Including Candida auris.
Yes.
For anyone not following infectious disease news, Candida auris is a highly drug-resistant fungus. It has been causing absolute panic in global health communities because it survives on hospital surfaces for ages and just shrugs off standard antifungals.
It's a nightmare bug.
Yeah, the fact that a drop of specialized superglue neutralizes it is just wild.
And the real-world clinical outcomes actually reflect those lab results. There was this massive multi-center retrospective study conducted in Korea tracking over 2,000 patients.
It's a huge sample size.
Huge. When those hospitals completely replaced their standard securement protocols with this cyanoacrylate tissue adhesive, their CLABSI rates plummeted.
Oh, what to what?
They went from 3.66 infections per 1,000 catheter days down to just 1.84.
Wow.
They functionally cut their bloodstream infection rate in half.
Just by switching to a drop of glue.
Yeah.
And beyond the infection rate, there is a massive logistical benefit here, too. The adhesive seal lasts an average of 7 days.
Which is huge for the nurses.
Right. Nursing staffs and intensive care units are perpetually overworked. Eliminating the need to peel off and replace sweaty, failing dressings every 2 days frees up hundreds of hours of nursing time.
Absolutely.
Let me play the skeptic for a minute, though.
Please do.
Polyurethane catheters are thin, flexible plastic. Cyanoacrylate is a harsh chemical adhesive that undergoes an exothermic reaction like it generates heat when it cures. I would assume that applying superglue directly to a thin plastic tube would cause chemical degradation. Aren't we risking melting the catheter and having it snap off inside the patient's vein?
That is a very valid concern, and it's the exact hypothesis researchers tested in a critical proof-of-concept study published in the journal Medcrave.
Oh, really?
Yeah. The researchers didn't just visually inspect the catheters after gluing them. They utilized Raman spectroscopy and scanning electron microscopy to analyze the chemical bonds and the ultrastructural integrity of the polyurethane after it was exposed to the 2-octyl cyanoacrylate.
Okay, wait. Raman spectroscopy. That basically bounces lasers off a material to see how the light scatters, right? Which tells you exactly what molecules are present and if any chemical bonds have been broken or altered.
That is the exact mechanism, yes. And the spectroscopy revealed zero microstructural degradation.
All zero.
None. The cyanoacrylate cures on the surface of the polyurethane without actually altering the chemical makeup of the plastic beneath it.
That's incredible.
They even took it a step further. They tested what happens when you use chemical solvents, like acetone, to remove the cured glue after a simulated 10-day dwell period.
Acetone. But acetone eats through almost everything.
You would think it would compromise the line, but the electron microscopes confirm the catheter remained perfectly intact, with no signs of pitting or structural weakness whatsoever.
So the clinical conclusion is that it is highly effective against bacteria and entirely safe for the medical hardware.
Exactly. Safe and effective.
So applying this liquid adhesive successfully seals the front gate of the castle. The drawbridge is locked, the moat is dry, and the barrier is impenetrable. But as we know, the deep dive isn't over.
Never.
Because bacteria are opportunistic. If they can't breach the front gate at the skin, they simply bypass it and go for the back door.
Right. And in the architecture of an IV line, the back door consists of the tubing connections.
The hubs?
Exactly. The catheter hubs and the needleless connectors. Those little plastic ports hanging off the patient's arm where nurses attach syringes to push medications.
This part of the research actually blew my mind, because the CDC notes that hospitals previously recognized these hubs were a problem, so they switched to specialized mechanical safety valves to try and prevent infections. But the intervention actually caused massive outbreaks.
It was a disastrous backfire, honestly.
How does a safety valve cause an infection?
Well, the hospitals transitioned to mechanical valves, specifically positive and negative fluid displacement valves, thinking it would prevent blood from backing up into the line.
Makes logical sense.
The problem was the physical design of the valves themselves. They featured these opaque plastic housings and really complex internal corrugations and springs.
So they basically created a labyrinth inside the tubing.
A labyrinth with microscopic dead spaces where fluid and blood could easily pool. Organisms would harbor in those internal corrugations, completely hidden from sight.
Oh, man.
Yeah, a nurse could wipe the outside of the valve perfectly clean, but the bacteria were multiplying inside the mechanism, just waiting to be flushed directly into the bloodstream the next time a medication was injected.
That is terrifying. So how do you guard the back door today? I know the traditional approach is an active disinfection technique called scrub the hub.
Right, scrub the hub. Before a nurse connects anything to the IV, they tear open a little alcohol prep pad and physically scrub the connector with friction for anywhere from 5 to 15 seconds.
But the literature shows that active scrubbing is highly effective, right?
It is highly effective, but only if it is executed flawlessly every single time. And this is where we really have to factor in human factors engineering and the realities of modern medicine.
Right, because an ICU nurse might have to access a patient's line 30 times in a single shift.
Easily 30 times. And they are dealing with alarm fatigue, multiple critical patients, and just constant interruptions, relying on a human being to perform a perfectly timed, vigorous 15-second manual scrub, and then wait another 10 seconds for the alcohol to completely air dry, dozens of times a day.
It's a protocol inherently designed for human error. It's like relying on someone to perfectly floss and brush their teeth after every single sip of coffee they take throughout the entire day. Eventually, they're going to skip it or rush it.
They absolutely will.
Which totally explains this shift to passive disinfection. I've actually noticed these bright green or orange plastic caps twisted onto the IV ports in modern hospitals.
Ah, yes. Those are disinfecting port protectors. They're commonly known by brand names like Kuros caps. Instead of relying on a nurse to actively scrub, these are small plastic caps that contain a sponge internally saturated with 70% isopropyl alcohol.
So the nurse just twists the cap onto the needleless connector whenever the line isn't actively being used.
Exactly.
It's like soaking your toothbrush in a jar of mouthwash between uses instead of just rinsing it in the sink.
That is a great visual. It bathes the access point in alcohol. The clinical data shows that these caps completely disinfect the surface of the connector within 1 minute of application, and they maintain that sterile environment for up to 7 days if left in place. The brilliance of passive disinfection is that it removes the human error from the equation completely. You are no longer relying on a perfect 15-second scrub. The cap is actively disinfecting the port continuously, 24 hours a day.
You are leaving a permanent guard stationed at the back door instead of asking a nurse to run over and check the lock once an hour.
And the impact on compliance is massive. The systematic reviews consistently demonstrate that integrating these passive disinfecting caps into standard hospital bundles leads to a dramatic, statistically significant reduction in CLABSI rates across totally diverse patient populations.
So what does this all mean for you, the listener? Whether you are prepping for a routine surgery, sitting beside a loved one recovering in the ICU, or you just have a deep curiosity about how medical engineering actually functions on the front lines, it gives you a totally new perspective on the invisible war happening right on the surface of the skin.
It really forces you to realize that in medicine, the most microscopic details dictate life and death. A microscopic wiggle of a plastic tube or just a tiny drop of trapped moisture under a piece of tape can initiate a catastrophic infection.
But on the flip side, human ingenuity has figured out that a single drop of cyanoacrylate adhesive or an alcohol-soaked plastic cap can mean the difference between a rapid recovery and a life-threatening systemic crisis.
It's a game of millimeters.
It really is.
Yeah.
Next time you look at an IV line, you aren't just seeing a simple tube delivering fluids. You are looking at a highly engineered, heavily fortified defensive perimeter. But, there's one detail in the research that I haven't been able to stop thinking about, and I want to leave you with this.
Whoa, let's hear it.
In the CDC guidelines discussing emollient protections, they casually mentioned that certain antibiotic ointments, specifically one called mupirocin, can literally cause the spontaneous rupture of polyurethane catheters.
Yeah, that's a scary one.
The chemical makeup of the ointment just silently degrades the plastic until the catheter snaps entirely.
Which is exactly why the industry relies on the cyanoacrylate adhesives, which, as we now know, sit safely on the surface without interacting with the polymers.
Right. But it highlights how incredibly delicate this whole interaction is between synthetic materials, chemicals, and human tissue. It made me realize that we are still fighting this battle from the outside in.
What do you mean?
Well, what if the future of infection control has nothing to do with figuring out which external superglues or alcohol caps to apply to the skin? What if we are looking at the problem entirely backwards?
Oh, you're talking about abandoning external securement altogether.
Imagine a future where the catheters themselves are manufactured from bio-integrated smart materials. Materials that don't just sit inside the vein, but intrinsically fuse with the human tissue the exact moment they are inserted.
Like a material that actively mimics the body's natural cellular healing process, instantly sealing the puncture wound from the inside out the second the needle is removed.
Exactly. The catheter becomes biologically indistinguishable from the surrounding tissue. It would render transparent dressings, chemical moats, and tissue adhesives completely obsolete.
That would change everything.
Instead of spending billions of dollars figuring out how to best guard the lower drawbridge, what if the drawbridge just built its own impenetrable castle wall behind it? Something to think about next time you see an IV.